Similarly, a laboratory or any institution cannot function without a leader and an administrator. And of course, we had Kiran Madam, who was a workaholic and a very able administrator. Because I contributed in a very small way to the growth of the lab. Next one. And actually, we started, as I said earlier, in a very small place behind Periyamma's outpatient department with mainly a manual setup. Then came the revolution, and we had inducted the Sysmax 3-part analyzer, which was then introduced. And then, of course, Selectra E, that the machine that you can see there, and that was initiated by EMAC. And we were actually the first one to introduce this in the market, and we also benefited by that. And in a very small group of handful of technicians, which you can see on the right-hand side with the old laboratory building, we have grown 10-fold increase in the laboratory staff. Next slide. And now you can see the fully automated lab with its all wings. We had a small puja celebration to commemorate the journey. And that is actually, we have all the fully automated specialities of the lab, the microbiology, immunology, serology, biochemistry, histopathology, cytology, hematology, and immunocytochemistry. So it is a fully automated lab, and almost all the investigations which the clinicians want are all being done here. Not only the laboratory work, unless you update yourself, you cannot grow. So we had a lot of academic activities, and we had more than 10 CMEs, continuing medical education program, mainly for the laboratory professionals and the paramedical staff. And all the guest speakers you are seeing in front of you. And the crown in the glory was the IQMA Tamil Nadu chapter, which we held in 2019. That was a great success. Next slide. Not only the academic activities, we also had team bonding activities which brought us all together. And it was for the benefit of all the technicians. And the hospital hosted a lot of cultural activities and sports event. And no hospital function will go without the laboratory participating in it. What you can see is the many accolades and the prizes which were all won by the hospital staff. Of course, we had time for romance too. And these are the lovebirds, which you can see in the photo. And, many of them had married the staff nurse. Don't tell me how they got connected. I don't know. And many of the laboratory technicians married their colleagues. And the beauty of the story is all of them are still with us. More than 10 years of service, 90% of our technicians have grown along with us. And the longest service is by Rekha, who is more than 17 years. That is a great achievement of the laboratory, I should say. And then with the growth of the hospital and the lab, and this is actually the 5th time we have shifted, as all of the people who have logged in and the senior people would have known. Then came a breath of fresh air in the form of Dr. Akshit. And she entered and inducted the work culture and discipline and, of course, accreditation attached to NABH. And undoubtedly, Samir, the pocket edition of our chairman, he was the guiding force behind getting the accreditation process going through. And of course, Dr. Vijay Kumar, the head of the biochemistry department, he helped us in upgrading the biochemistry department according to the need of the clinician, performing all the various investigations which they wanted. And now, feather in our cap is now the recent addition of a molecular laboratory by Rivera Lab. So I take this opportunity to welcome the Rivera Lab. And I also, once again, welcome all of you to take part in today's inauguration ceremony, as well as the CME connected to that. The theme of the CME is molecular aspects in clinical practice. All the experts in their respective field are going to talk to you on their experience in their respective field. I once again welcome you and thank you for your listening. Thank you.
Thank you, ma'am. Light symbolizes brightness and prosperity. It is a motivation harbinger of wisdom and knowledge. We now have the lighting of Kuthuvilakku. I request Mr. Dilip Mehta, Chairman, Mehta Multi-Specialty Hospitals, and our pillar of support to deliver the inaugural address.
It gives me immense pleasure to deliver the inaugural address on the eve of the inauguration of our renovated laboratory and molecular diagnostic laboratory. Our laboratory is like a jewel on the crown, like Kohinoor diamond on the crown of Dr. Mehta's. Our physician and consultants are immensely happy with the services of our laboratory, which is renowned for accurate and quick results, timely responses, and critical alerts. I am overjoyed that the laboratory is expanding its services and celebrating 35 years of its proud existence. It had started as a small bedside laboratory with a handful of technicians, and it has grown with the expansion of Dr. Mehta's hospitals. The reputation of the laboratory is due to the relentless, dedicated leadership of our Dr. Sita Lakshmi, ably assisted by Dr. Akshit Timaya and Dr. Vijay Kumar, and the team.
Thank you, sir. Molecular diagnostics is among the fastest growing sub-segment of the in vitro diagnostic market. Mehta Hospital has collaborated with Rivara Labs to harness the power of molecular diagnostics to bring need-based diagnostics as well as point-of-care solutions. I request Dr. Kannan, Medical Director, Mehta Multi-Specialty Hospitals, to welcome the new molecular laboratory in our premises by the Rivara Labs.
Good morning to you all. It is my pleasant duty to welcome the new entrant to our family, Rivara Lab. Rivara Lab is a young startup incorporated in 2019 into Daftari Group of companies. This laboratory is manned by highly competent technical personnel. It is a state-of-the-lab laboratory rendering molecular biology services to the community at large. The lab has partnered with a hospital of great legacy, that is Dr. Mehta's, and this partnership, I am sure, will render great dividends to the community at large and to the patients coming to our hospital. I wish the endeavor all success. Thank you.
Thank you, sir. Rivara Labs provides state-of-art molecular testing as an integrated consultative element for advanced patient care. One of the driving forces of Rivara Labs is trust, and they imbibe this by maintaining the highest standard of quality in everything they do. They work with patient-centric mindset and foster an inclusive culture, providing a tailored approach to treatment of patients. I request Mr. Shyamakant Giri, CEO, Rivara Labs, to take us through their services offered.
Thank you. Thank you very much, team, Dr. Mehta. Can you hear me? I think.
Yes, sir.
Yeah,
we are
yes,
able to hear.
Okay. Thank you very much. Thank you very much, team, Dr. Mehta, and congratulations to the lab team for completing 35 years. I think this goes. This tells about the journey. It tells about the compassion and dedication that the lab team has. My name is Shyamakant Giri. I am the CEO at Rivara Labs based in Mumbai. What I will do in next 10 minutes is to tell you who we are, what we do, and how this lab in Dr. Mehta's is going to become the finest molecular biology lab of the city. Okay, so our intent is we want to play in two fields, which is molecular diagnostics and point of care technology, and that's all. So we are not a chemistry or immunology player. And I will tell we have reasons of why we want to limit ourselves in molecular diagnostics and point of care technology. But the biggest goal is to provide doctors and patients achieve timely and superior clinical outcomes. Next slide, please. Now, no, a little behind. Yeah. So we are not a startup. We belong to this group of company which is already into healthcare for last 30 years. Now, if you see on the screen, these are companies owned by the group. We have a pharmaceutical company by name Bharat Serums and Vaccine. We have a IVD reagent company by name ADVI with offices in Japan, Europe, US. We also own a IVF clinic, chain of IVF clinic in West India. And we were into pathology business since 1970 with our lab in Mumbai. And we also have a clinical research organization by Zero. So we know healthcare, we understand diagnostics, we understand patient. There are 3,000 of us who are serving this population since last 30 years. Next slide. And this is what each of us in Rivara live by. These are the values that we demonstrate in our daily behavior: respect, speed, trust, innovation. And this is what, from a patient standpoint, if I were to see from the lens of patient, this is what patients also demand from any service provider, whether it is a lab provider or a hospital provider. Next slide, please. This is Rivara Lab. So we have three verticals of businesses. One vertical is called as RT-PCR vertical. We have point of care vertical, and we have NGS vertical. I will little dwell on the RT-PCR vertical. Next slide, please. In RT-PCR vertical, what we do is we are opening molecular diagnostic lab across India. And the question is, why molecular diagnostics? Next slide, please. Apart from the commercial reason of that this market is growing more than 12-15%, the biggest reason of why we are here is to address the unmet need. We have done our own research encompassing 200 doctors in India and realized that 45% of the physicians, they don't know how to leverage a molecular diagnostic test. They don't know how to read a molecular diagnostic report. And you will be surprised when I say that only 9 cities in India, they process 90% of molecular biology samples, which means the sample flow from that city to this city, and it gets processed in this city, and the reports flow out. That leads to TAT. Okay, in molecular biology business, 48-hour TAT is something which is normal. Nobody is challenging that, and we are here to disrupt that. Okay. And from an innovation standpoint, from a molecular biology test standpoint, if you see largely 80% of physicians would talk about hepatitis B, hepatitis C, HIV, malaria, dengue, TB, and that's all. The whole world is evolved around multiplex systems and all that, which is still not gone to the physician. And the physicians would like to use a multiplex test to make sure to diagnose the element correctly and to bring speed in the clinical decisions. Next slide, please. So our business model hinges on this 3 triad: accessibility, affordability, and awareness. Now, accessibility, you will be surprised that even after COVID, the India currently has around 1,500 PCR machines for a population of 1.3 billion. And the biggest issue of accessibility is most of them are in metro towns, most of them are in main towns, and therefore the sample flows from wherever they are to this metro town to get processed. Our model is to make it accessible. Our model is to make the PCR lab reach people instead of people reaching PCR lab. At the same time, there is a lack of awareness in this category. Physicians have no idea how to leverage a molecular biology test in their daily clinical decision making. We are here, to do that. And the third important aspect is affordability. Because of low demand and low supply, the prices of molecular biology kits are also on a higher side. So this three triad is something that we are going to address. Next slide, please. So as I told you, these are the three things. How do we be accessible, be affordable, and make people aware, or physicians aware, so that they can take superior clinical outcomes. Next slide, please. So now coming to accessibility, this is our plan. We are opening 60 RT-PCR labs in 6 cities over next 1 year. I'm very happy to say that we actually have 21 labs that will be live, that are live, okay? And then we have 60 RTP. No lab chain company has ever done this. We are going to do this. We have this hub and spoke model. So our hub will be a central reference lab based out of Mumbai, and in the future Bangalore, Delhi, Calcutta. But as of now, Mumbai, which has genomics, Sanger, NGS, and all of that. And this will be supported by 60 RT-PCR labs across India. Okay, this is many ways what we are doing is democratizing the molecular biology in this country, and we are the first company to do so. In chemistry, many have done that, but in molecular biology, we are the first company to do so. Next. And we have reasons to believe that this accessibility will in a way help physicians of that town, of that region, take clinical decisions faster. Next slide, please. The way we do that, our business model is very simple. We go to a town and we go to the best hospital of the town and we ask them to give us a space for us to build and run a molecular biology lab. Once we do that, we have a sales team and a service team who goes and promote our unique RT-PCR test in that city. And not only we end up processing the hospital sample in that hospital, we also end up processing the city sample and the region sample in that hospital. And everything is tied up with a very beautiful best-in-class IT system, a LIMS system, so that there is full transparency between partner hospital and us in terms of what is happening when. Okay, so this is a very unique model again to open our RT-PCR lab only in a hospital. And we have done that in 20 cities so far. Next slide, please. So we have 74 test menu that we begin with across 9 therapy areas. We cater to hospital infections, respiratory, STD, oncology, neurology, gastro. And very important part of our test menu is that more than 50% of our menu are multiplex kits. That means they can do 2 or more pathogen in the single run. And more than 60%, 60 kits that we do is we import that kit. So we are not into homebrew business. Our kits are validated, CE approved, coming from a best companies of the world, and we have access to 74 tests. So Dr. Mehta's will be doing 74 tests of microbiology RT-PCR in the lab that is there. Okay, by far this is the largest number of tests that can happen in a lab. We have all the data which shows that most of the molecular biology lab in the city, they do some tests, they outsource some tests, they send it to the parent central lab for some tests. But Dr. Mehta's lab will do 74 tests in Dr. Mehta's in the lab. Next slide, please. And if you see our model, as I told you, we have best of the corporate hospitals and best of the hospitals as our partner lab. In Bangalore and Pune, our lab is in Columbia. In Coimbatore, it is KG Hospital. In Calicut, it is Baby Memorial. In Raipur, it is Ramakrishna Care, and so on and so forth. Okay, as I told you, we have labs live as of now. In many ways, we are a COVID child because all this has happened during the COVID period. Next slide. And what we have done, this is the accessibility part, what I just told you in terms of how we want to make ourselves accessible. Now on the affordability part, we have actually acquired a manufacturing company 2 weeks ago in Bangalore by name Genie Labs. Genie Lab is the oldest domestic brand. This company was started in 1989 and they do RT-PCR manufacturing kit. And this is how we are going to make our kits affordable in the future. And this is something that has happened 2 weeks ago, and I'm very happy to share with this group of this acquisition that we have made. So we are vertically integrating ourselves. We are not only a service provider, we also will manufacture our own kit at a unique lab here, validate it, see, approve it, and then use it ourselves in the lab. And that will give us the advantage of cost, and that is how we want to become affordable. Next slide, please. And with this acquisition, we got 25,000 square foot of state-of-the-art facility of RT-PCR manufacturing kit. Next slide, please. Okay, so this is how the affordability will come in. And very broadly, if you then summarize what is our Rivara strategy of molecular biology, the first advantage is a geographical footprint that we want to achieve across these 60 cities that I just told you. The test menu strategy, which is offers a unique test with a high turnaround time, with a lowest, I'm sorry, with a quick turnaround time of less than 24 hours. Pricing is one because of the fact that we have our own RT-PCR manufacturing facility. At the same time, we want to add value. The focus really will be to generate value and help physician take faster clinical decision, and a very unique physician outreach model. We plan to hire 200 field force in the field so that they can communicate the advantages of molecular biology across India, and within a very unique in-hospital lab model. And this is of course covered by best-in-class service, whether it's IT, runner, Flebo services, LIMS, etc. Next slide, please. We also have our scientific advisory board as we are building up. As of now, we have two doctors, Dr. Preeti Lal from US and Dr. Arvind Rai, who are part of our scientific board and helping us not only, guiding us not only to design the lab, but also to design various innovative kits that we plan to market in India. Next slide, please. We also do many webinars. We also we feel that only opening lab will not help unless we assume the role of information leader. And so every month we have webinars with speakers from India, with speakers from US and other countries, highlighting the importance of molecular diagnostics in day-to-day practice. Next slide, please. Now coming to lab at Dr. Mehta's. Next slide, please. So this is the lab that we have at Dr. Mehta. This is a BSL level 2 lab. Okay, it has a 96 well Constudio PCR and an automatic extractor in the area given to us by Dr. Mehta's. We have set up the lab in a way that we can do up to 300 tests per day on day one. That's the capacity we have built on day one. We have 74 tests in the menu. The lab is led by Dr. Akram Hussain, who is a PhD titled as Lead Research Associate, and Kirtana, who is our Research Associate. We have a commercial team based out of Chennai. Prabhu is our area sales manager, and Vijay is based out of Chennai, our regional business manager of South. And the key HO staff that you may like to know are Debashish Chaudhary, our commercial director, Dr. Madhvi Pusalkar, our national lab manager, and Chaitra, our lead of medical affairs. Chaitra right now is in Chennai with you. So this is the lab which is going to become the finest lab in Chennai. Next slide, please. So this is what we have done. This program called a SPACS program is something that we implement in the lab from day one. PACS program allows us to become patient-centric, approachable, with high quality output and the highest speed. Okay, so this is an internal program that we implement in each and every lab. Okay, so this is something which is already there in the Chennai lab, and I want to highlight some of the key things of this lab. The first key thing is the LIMS that we have. Now, this LIMS will not only speak to the LIMS of the hospital, but this LIMS will allow the patient to see the reports on WhatsApp, email, allow the physician to access the report on any time of the day they want. So this we have tied up with one of the best LIMS company of India. I already told you about Constudio and the extractor that we have, uh, the way we have started the lab. Next slide, please. Now let me just talk about the innovative kits that we have launched in Chennai, which will make us very unique, and that's why I'm saying that we'll end up becoming the finest lab in Chennai. So for the ICU people, we have sepsis panel in blood. Now this is the first time that we can do sepsis panel in blood. Normally, traditionally, a sepsis panel happens on a cultured blood. Therefore, the TAT is more than 36 hours. We can give you the result within the hospital in 6 to 10 hours. And this is a very unique panel that we are launching in Chennai. And Dr. Mehta's had the advantage of use it to themselves, which is a sepsis panel in blood. Okay, very high sensitivity. We have a fungal ID panel. We have a resistance panel only for carbapenems and colistin, which are the mainstay ICU antibiotics this point in time. So this is for ICU team. Next slide, please. Then similarly, we have this respiratory pathogen, 21 pathogen in single run, a very unique panel again, where a pulmonologist can run and determine the causative pathogen in the respiratory patients. We have a bacterial pneumonia, community acquired pneumonia panel, and we also have a atypical community acquired pneumonia. This is all multiplex. For gynaes, we have a unique urethritis panel. UTI, which is one of the common thing in urinary tract infection in gynaes. This is the first panel that we have launched in Chennai, and we have a very comprehensive STD panel covering 9 pathogens. Next slide, please. For gynaes, similarly, we have unique panels in gastro, neuro, like viral meningitis, neonatal meningitis. In gastro, we have viral gastroenteritis, bacterial enteritis. Similarly, we have a very unique panel of fever and rash, especially for pediatric patients. Next slide, please. Now, on the COVID testing side, 21st December is when the NAB is going to happen. We expecting to receive the COVID approval by 26 December. So on 21st December, this lab also will be NABL accredited. And before that, except for COVID, we can do all the tests right now. We are inviting samples. And this is our unique Caroline number. You want to ask anything, book a test. This is a very unique number that will be calculated to all the physicians in Chennai. And we want to go as close as to the patient. I really thank Samir Mehta and the staff of everybody of Dr. Mehta's hospitals for placing that trust on us. And we are obliged, and we will be standing to the trust that you have placed on us. The lab is open now. I want to thank again everybody for the patience. If there's any questions that you have, you can type on the chat box and you can ask. And thank you again.
Thank you, sir. It was an eye-opener for all of us. Moving on, Dr. Thupil Venkatesh is the CEO and Director of the Foundation for Quality India. He is also the Emeritus Professor at St. John's Medical College.
Dilip and Samir.
He is fondly called the lead man of India and is the lead assessor of NABL and NABH. He is also advisor to CAHO and AHPI. He will deliver the felicitation address.
My dear Dilip and Samir, thank you very much for inviting me to the inaugural ceremony of the new diagnostic center lab complex at Chitpet on 12th of this month. I tell you, today's diagnosis is tomorrow's medicine. Now you have completed 35 years of laboratory diagnostic services to the people and needy persons of Chennai and surrounding places. On this occasion, I would like to wish you, especially when you have started the molecular diagnostic lab, which is the need of the hour when there is a COVID pandemic all around. This is something which everybody is looking for. I personally, I would have been very happy to be there personally on this occasion. Due to several reasons, I'm sending this message to you. Physically, I may not be there. Mentally, emotionally, I'm part of the whole ceremony. I take this occasion, opportunity to wish you, your colleagues, your staff, and all the laboratory people all the best in days to come. Thank you very much.
Thank you, sir. I request Dr. Akshit Timaya, Head of Lab Services, Mehta Multispecialty Hospitals, a dynamic leader without whom all these would not have been possible, to deliver the vote of thanks.
Good morning, everybody. I'm very overwhelmed to sit here today and witness this day because it was conceived as an idea or a plan about 4 years ago, and it has taken a long time to complete. When the entire project started, I didn't think that it would be so challenging and so humongous. Well, 2020 hasn't been very kind to any of us. But we are here, and I would like to call this as a new beginning for yet another chapter at Dr. Mehta's. It wouldn't be possible without thanking many people in this journey. And one of the most important people is our group head and CFO, Mr. Jeevan. He's not the one to grab the limelight. He's not even here. And he's there in the Zoom call who's joined us. But he's always there when we hit the roadblock and need guidance. Thank you, sir, for giving us a free hand to execute this project. I've been with the Institute for about 9 years now, and I've seen it grow leaps and bounds. It wouldn't be possible without the fast-actedness of the senior family members and the senior LT members. Mr. Samir Mehta for always pushing me out of my comfort zone to identify new talents. I'm sure I can get a master's degree in designing now. Thank you, Samir. Mr. Dilip Mehta, who has been so accommodating with all our requests at any time of the day. Thank you, sir, for being the guiding line. All our senior LT members for giving their inputs. I especially need to thank all the other LT members, especially the AC technicians and team, the electrical team, Ms. Puma and her operation team, the drivers. I need to especially thank our drivers during our COVID time, and also this time when we needed them the most. So thank you so much for the entire drivers team. The biomedical team, that is Ms. Ramya and her team, for being there to procure our instruments and being there to sort out all our instrumental problems. The nursing team, you might wonder why I'm thanking you, but you've been so supportive and accommodating during our shifting process whenever there was a delay in the testing, right? So you have always been there to support and been a kind of bridge between the doctors and lab. So thank you so much. I hope I've not missed anybody. And the maintenance team too. They are required every day for us in helping to sort out a lot of problems. Other than this, I would like to thank Devashilpi, our infrastructure partner, for bringing life to something which we had envisioned. Rivara team, who is also here, thank you so much for partnering with us, and hope this partnership continue and bear great fruits for both of us. It wouldn't be possible until and unless I thank my entire laboratory team. When you go for a war, right, you have a general and you have a commander-in-chief. Without the commander-in-chief, who is a bridge between the two parties, that is a strategist and actual person to do the work, it wouldn't be possible. So I have my commander-in-chief, that is Mr. Tyagarajan, who's always acted as a bridge between both the team, both the players, and always got the work done. Thank you, Tyagarajan. You've been a great support for me. Mrs. Sita Lakshmi, ma'am, was always smiling and telling me whenever we hit a roadblock, it's always telling me that Akshay, this will also pass. Don't worry, we will finish the project. Thank you, ma'am. Dr. Vijay Kumar, who's also here, who's brought in with him years of experience to get this project. Our new team members, that is Dr. Lydia and Impana, who have given us a lot of inputs. I would also like to thank one of the people who have not been with us at present, is Letter Institute, Ms. Dr. Bashman. Dr. Bashman, even before we started the construction, he was there with me to go into every department, take measuring tape, we measured everything. So in planning the entire thing, he was a great support, and it wouldn't be fair on my part if I don't thank him at this point of time. Thank you, Bashman. And the entire laboratory team, every technician, every housekeeping person who has been there, who's helped us move things, accommodated our requests. Thanks to the entire laboratory team to be such a big strength for me. It wouldn't be possible without our sponsors. Many of these sponsors which you're seeing on the screen have been associated with us for more than 20 years. So they have been there with us, to the thick skin of our journey. They've been very accommodating during our rough patches. Thank you so much for being there for us and also contributing so generously towards this event. I might have not mentioned a lot of people, but you know who you are. If you know who you are, please pat your back. And thank you so much. I invite all of you to come and see our laboratory about what it was and what it has become. Thank you so much.
Thank you, ma'am. Let us all stand for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे
Thank you all for participating in the inaugural ceremony. Now we go on to the technical session. Recent revolutionary progress in human genomics is reshaping our approach to therapy and diagnosis. Molecular pathology is becoming a crucial diagnostic tool, not only in the setting of inherited genetic disorders, but also in a wide variety of neoplastic and infectious processes. Keeping this in mind, the lab team of Mehta Multi-Specialty Hospitals are very happy to organize this CME on molecular aspects in clinical practice. The first talk of the day would be by Dr. Tulasi Raman. Dr. Tulasi Raman is a consultant in the Department of Hematology, Apollo Specialty Hospital. He did his MD Pathology from Dr. NTR University of Health Sciences, AP. He also holds a DNB degree in pathology. He has authored 14 national and international publications. His areas of interest include flow cytometry, pediatric pathology, and primary immunodeficiency. I request you, sir, to enlighten us on the ancillary techniques in diagnosis of hematolymphoid malignancies.
I hope you can hear me. Am I audible? Am I audible?
Yes, sir, you're audible.
Yeah, but I couldn't able to share my screen.
Yes, sir, 1 minute.
Yeah. Yeah.
Sir, to share the screen. Yes, sir, you can start sharing it.
Yeah. Yeah.
Yes, sir.
So very good morning to everyone. And at the outset, I would like to congratulate Mehta Hospital and the Department of Laboratory Services for their new laboratory complex, and also including the molecular into their armamentarium. And I'll also thank for the opportunity given to talk on auxiliary techniques in diagnosis of hematolymphoid malignancies. Given the time is 15 minutes and talking on molecular, I couldn't, I cannot go very deep into the topic of molecular, but what I can do is I can share some interesting cases where these auxiliary techniques will help us in the diagnosis. So there has been a great improvement and revolution in the last decade with respect to the diagnosis in hemato-oncology. So we basically approach the diagnosis with clinical features, a blood count, peripheral blood morphology, and cytochemistry. And now it has become a situation where the additional tests like immunophenotyping by flow cytometry, cytogenetics, and molecular genetics have become mandatory for a good diagnosis or a proper and a correct diagnosis. So why you need all these auxiliary techniques like immunophenotyping, cytogenetics, and molecular is basically to have a very correct diagnosis and to classify the disease properly. You have to risk stratify the patient before you start your treatment, because we should know how he's going to behave for your treatment, whether he's in a poor risk category or he's in a good risk or in a good risk category, so that we can able to tell the outcome of the disease prior to the start of therapy. And now to select a proper treatment, now it's all more like a targeted therapy. So knowing your molecular defect or a molecular mutation, you can give a targeted therapy to the patient who can respond better. And you also have to follow up or the response for the treatment what you are given, whether your treatment is working with the in the patient or it's not. So you can also follow up the response how your treatment is working. So for assessing the response also, you can use all these auxiliary techniques, which I can show you in the upcoming slides with examples. So now this is the hematolymphoid WHO classification, and you can see almost all the entities have a tag of genetic attaching to them. So that is how important now genetics has turned to be in hematology practice. Even the basic criteria we have been taught from our PG days or even from undergraduation, say like a blast, if you want to call acute leukemia, the blast percentage should be greater than 20%. But now, if there is a genetic abnormality or which is very significant or which is a characteristic of that particular disease or a malignancy, even that criteria can be relaxed. So that crucial is molecular in practice of hematology. Now again, coming to risk stratification, as I said, we need to before we start the treatment, we need to risk stratify the patient to give him the correct treatment. So those who have a good response may start with a good normal protocol, and those who are in a poor risk category should be given an augmented and an effective or more effective protocol for clearing the disease. So here I just shown an example of acute leukemia, and this is B acute lymphoblastic leukemia, where I have highlighted in red the genetic abnormalities which belong to the poor risk group, and the green is a high, it's a good risk or a better outcome group, and this is intermediate group. Similarly, in AML, I've shown you some favorable group which has this recurrent genetic abnormalities, and there is others are intermediate and adverse groups. So even genetic helps you in risk stratifying the patients before you start your therapy. As I said, this targeted therapy and translational genomics is coming up in a big way. Of course, in next decade or some, so all your treatment will be very personalized. That it is directed towards the mutation or the abnormality what you have. So it all started with imatinib, where they first found the drug for BCR-ABL positive CML, and now it is going for every other disease. You have inhibitors for FLT3, IDH, and even JAK2 inhibitors. So this is translational genomics or targeted therapy, where it is coming up in a big way. And again, you need to know what is the genetic abnormality lying in the disease, and also the proteins expressed in the disease. So you can give a very effective therapy rather than giving some empirical therapy. So, and final thing is how the patient is going to respond to your therapy. That is by MRD detection. MRD is minimal or measurable residual disease detection, which is something like you need to detect the residual leukemic cells, which is less than the morphological limit of detection. Normally now we do bone marrow microscopy, where we try to detect 1 in 100 cells, but that is not enough to say the patient is in remission. You need to go deep into that. So this photograph shows that it has to be assessed at the level of 1 in 10,000 cell and even in 1 in 10 lakh cells. So it has to be gone into that depth to avoid that florid relapse. Once you feel the MRD is coming up or the small population, the disease again picking up, you can augment the therapy and again make the patient to go for remission. If you leave and it's going to be a florid relapse as shown on the left. So even these techniques, especially flow cytometry and PCR, is very useful in assessing the MRDs. PCR is very useful when there is a known cytogenetic abnormality, so that you can target the primer to that. If you don't have any known genetic abnormality, you can go with flow cytometry. So this is the status of MRD detection. It's like you need to find the needle in the haystack. You can't practically do it, but when you have good techniques, you can easily find the MRD, as in this case. So basically we use two things for MRD detection currently. One is IPT, that is immunophenotyping by flow cytometry. The other is PCR. As I said, PCR is more effective when there is a known translocation, say like APML, where you know the translocation and you can, and even in CML. Whereas when you don't know the translocation or the genetic abnormality, you can go with IPT, where you do with DFN approach, or different from normal approach. So let's go into the cases now. This is a 1-year male child with pancytopenia and hepatosplenomegaly. Peripheral blood were showing blast as seen here. The blasts are very scant cytoplasm and the chromatin is very condensed. So morphologically, we would say this is, yes, acute lymphoblastic leukemia. But now, is it B or T? Because B, you have a different protocol of treatment, and T, you have a different protocol of treatment. So this is how the additional techniques will come into play. Now, we did flow for this case. By flow, the red population is a blast and the green is a lymphocyte population. The blasts are positive for B cell markers, which is CD19 and 79A, which I have not shown here. But one strange thing is 10 is negative in this case. Normally we do have 10 positivity for BLL cases, but here 10 was negative, which is classical of a pro-B phenotype. Pro-B, which has a relatively bad prognosis. Pro-B phenotype. And this also showed an aberrant CD15 and a dim NG2, which is pointing towards, or this immunophenotype is very characteristic of MLL gene rearrangement. Again, the case goes into a poor risk group. So thus flow helps in you to diagnose the case, and it also helps you in stratifying the risk of this particular patient. So we did with, normally we do with fish, and as expected, it was MLL rearranged. So MLL is has a very multiple partner. So we use a break apart fish probe, where it clearly shows that the fusion signal is absent and the two signals are separate, whereas one is fused. And the other translocations like 1221, 119 and 922 were negative. So the child was started on UKLL 2011 protocol regimen B. And after 28 days of treatment with the above induction, the marrow was sent for post-induction marrow status. The bone marrow cytology showed no increase in blast, but however, we did MRD by flow cytometry. So I said MRD is detecting that low level of cells, which is not capable of morphological detection. While doing flow, yes, we found 0.06% of residual disease, which were 45 dim, 19 bright, 38 downregulated, and 34 positive. So MRD is positive with 0.06. Now, if the MRD is positive, so they will augment the treatment. If MRD is negative, they will progress with the current treatment. So this case received an augmented BFM consolidation because it's MRD positive. So MRD detection plays a very important role, and it's one of the important prognostic indicator for the disease. Now, this is a second case. Again, there is peripheral blood with circulating blast. Morphologically, the blast show very scant cytoplasm. The chromatin is condensed. I thought like, yeah, this could be a lymphoid leukemia, acute lymphoid leukemia, and we did with flow. So flow showed, again, red is blast and green is lymphocyte population. The blasts were positive for stem cell marker 34, myeloid marker 117. It is negative for both the B cell markers, which is 19 and 20, and it is positive for a myeloid marker 13 and negative for 33. MPO was interestingly negative in this case. So the diagnosis is AML with minimal differentiation, where MPO can be negative and you have myeloid markers positive. So AML with minimal differentiation sometimes mimics like ALL, and if you are going by morphology, you may be going wrong. So you need to do phenotyping to confirm the disease. Now, this is another interesting case which was referred to us. There's a 3-month infant child with organomegaly, and BMA cytology were showing some large blast cells. So it was sent from the outside hospital saying like, is this acute leukemia? Query acute leukemia. Yeah, there were some abnormal cells like this. We did flow, but flow showed all these populations to be robust hematogones. Hematogones are nothing but normal progenitors of B cell population. Okay, so you can see a typical maturation pattern, and this is negative for leukemia. These are nothing but robust hematogones. Robust hematogones are very, very notorious, especially in infants less than 6 months of age, where they are seen in abundance, and even in post chemotherapy. And you need to differentiate them from leukemia. So advantages of flow cytometry is very rapid. It gives you the diagnosis in 3 hours. What type, and what is it like. So you can directly start on treatment. You do not wait for cytogenetics or molecular, which may take a relatively higher time. And it identifies some high risk group like MPAL, ETP ALL, and RAM phenotype AML. So the risk stratification can also be done at that level. And it also predicts, as I showed you, some flow can also predict certain genetic abnormalities. And it gives information about the ploidy status. If you are using a ploidy dye, it can show whether it's hyperploidy or hyperploidy. As I showed you in the other case, it can be used as a good tool for MRD assessment. So these are some of the phenotypes and their genetic predictors. So I just don't want to go very deep into it as there is lack of time. But flow can, they can predict some genetic abnormalities. And this is a case where we had a very dry aspirate, and we found this clumps of megakaryocytes here, and these are all megakaryocytes in clusters. And trophine biopsy also confirming that a lot of abnormal megakaryocytes with a lot of clustering, and there is a bit hypercellular marrow, and fibrosis were up to grade 1. This is myelofibrosis, and we did PCR for this, which came positive for JAK2 V617F. So myeloproliferative neoplasms are another group of hematological malignancies where your molecular plays a very important role. Flow has a very limited role, even cytogenetics has a limited role, but molecular has a very, very important role to play in myeloproliferative neoplasms. So these are non-CML MPNs where the mutations are there, and they assess, they can also give the prognosis of how the patient will respond. So CALR has the best prognosis, whereas the triple negative, which is negative for all CALR, JAK2, and MPL, has the worst prognosis. Now this is a case for a 48-year male presenting with pancytopenia. Peripheral blood showed macrocytic anemia, and a bone marrow and biopsy was done. So the aspirate we saw, there were dysplastic neutrophils. There was dysplastic, again, pelgoroid neutrophils, which are larger than the rest of the polymorphs. They are definitely dysplastic. And there were some occasional micromegakaryocytes. There were some myelocytes, and there are occasional blasts like this. And again, a lot of micromegakaryocytes. And this is a bilobed micromegakaryocytes, which is very, very classic of a myelodysplastic syndrome. Even trophine biopsy was showing all those findings of megakaryocytes. And so I strongly thought this is a diagnosis of MDS. I told to the clinicians that this is myelodysplastic syndrome. But the evening he called me saying like, is B12 is low. And he asked me, could that dysplasia due to B12 deficiency? Yes, quite possible. In B12 deficiency, you do get dysplasias. But thinking on, it's less likely because micromegakaryocytes is not very classically seen in B12 deficiency, and there was not erythroid hyperplasia. Instead, we found more of a myeloid hyperplasia. I said like, sir, it's less likely. Okay, then he said like, we'll do a myeloid MDS panel. So on doing an MDS panel, we found that there is a trisomy 8. So this is a normal cell where this is an abnormal cell, or where there are 3 signals for chromosome 8. So this is trisomy 8. So the final diagnosis is, again, the karyotyping confirmed that it's trisomy 8. And the final diagnosis was MDS with trisomy 8. We have a habit of doing sequencing for all myeloid neoplasms. When we did the myeloid gene panel was negative. So each has its own advantage. Karyotyping fish has advantage over molecular methods also. So this other case is a 70-year-old male patient with no prior hematological abnormalities, presented with HB of 9.9, WBC count of 21,700, and platelet count of 1.2 lakhs. So basically he has bicytopenia and increased TLC and no prior hematological abnormalities. Peripheral smear showed macrocytic RBCs. There were in the peripheral blood itself some dysplastic neutrophils like hypogranular and pelgoroid neutrophils, and there were some circulating blasts. Professional diagnosis on peripheral blood was kept as AML and MDS, and marrow was done. The marrow was very cellular, and even in this picture, you can see some giant band forms which are hypogranular and some dysplastic polymorph. Of course, there's a higher magnification showing those giant band forms, and they are relatively hypogranular. You can find this particular neutrophil, and again the same different focus of the same slide. You can find some dysplastic neutrophils not looking like normal, and there were some blast cells which were encountered, and again you can find a micro megakaryocyte here. So based on this, and refined biopsy was again very cellular. There was myeloid predominance. There were some hypolobated dysplastic megakaryocytes. Reticulin was not in, fibrosis was not there. Retic stain was showing no significant fibrosis. And we did with the CD117 and CD34 to enumerate the number of blasts. There were some blasts scattered. We did flow for this case, and marked dysplastic changes were seen in the myeloid and megakaryocytic lineage. We did flow. Flow showed 17% myeloid blast. So I thought like, okay, we are dealing with the case of MDS EB2 or excess blast, and MDS FISH panel came to be negative. Okay, negative, that's fine. And whereas the myeloid gene sequencing panel came to be JAK2 positive. So as we saw in the last case or in the previous slides, JAK2 is a very, very characteristic finding or a driver mutation of myeloproliferative neoplasm. Now, is it MDS as per the morphology, or is it MPN as by sequencing on the molecular method? What should I go for it? Or is it a combination of both MDS or MPN? So just taking with the MPN topic, just WHO gives a beautiful things of everything, MDS, MPN, everything. So just going through the book, we found that if harbor one of the any type of driver mutation like JAK2, it is more likely constitute MPN with features of disease progression. But however, if the chronic phase is not documented prior, and you find a lot of dysplastic changes with the driver mutation positive, it can still be labeled as MDS, MPN, unclassifiable. So the final diagnosis is MDS, MPN, unclassifiable. So this happens when you have the all workup being done. So this is a very interesting case. It's a 62-year female who presented with pancytopenia. This is the peripheral blood. The patient has very pancytopenic, and there were some cells with this projections or some flaming like thing. There is some cell with that nucleoli, and these are some blastoid cells. And the background showing some rouleau formation. I didn't find any typical plasma cells as such. But when we did flow cytometry showed the entire population to be plasma cells. It was 45 negative, bright 38, and a variable 138. It was positive for 56. And one more interesting finding is it was also both light chain negative. Of course, Edim lambda, but most negative. The B cells are normal B cells. The green signal, the green population is normal B cells, which are polyclonal. So this is a case of plasma cell leukemia. So morphology will be very deceiving. This is one other case what we published previously. The marrow was showing very high multilobulated or hyperlobulated cells, which were not looking like plasma cells at all. And with flow, it turned out to be myeloma. So morphology are sometimes very deceiving, and you need to be taking these additional techniques to establish a very good diagnosis. Otherwise, you may go wrong. This is possibly the last case. See, there are certain cases where the morphology will tell you that what is the genetic abnormality lying with them. This is one such case where when you see the morphology itself, you can tell this is the genetic problem with this particular disease. So this is a 48-year-old male presenting with refractory anemia. Peripheral image showed macrocytic anemia. We did a bone marrow and biopsy. So there's only anemia. The other things were normal, and the patient had macrocytic anemia. So this was a marrow aspirate. It's relatively a hypocellular to normocellular marrow, but in this cover itself, you can see a lot of megakaryocytes here, one more and one more. So here also. So there were megakaryocytic hyperplasia, and all these megakaryocytes were hypolobated. They were having only one single lobe, and even you can see here. So it's a very small megakaryocytes, not micro megakaryocytes, small megakaryocytes, but very, very hypolobated nuclei. The erythroid and the myeloid series were appearing quite normal. So just matching this is anemia, patient has anemia, but I do find some abnormal megakaryocytes. The erythroid and the myeloid looks normal. So this is very, very characteristic of MDS 5q deletion. So the presenting symptom will be anemia, but the morphology, the finding would be in the megakaryocytes. You find a lot of hypolobated megakaryocytes. This is 5q deletion, and we did a FISH for this turned out to be positive. There is absence of an orange signal, whereas the mapping signal green is present in. There are two chromosomes, but when there is an addition of long arm of chromosome 5, this is 5q deletion. So I conclude saying like you need to have everything in your diagnostic report that gives you a very good final diagnosis. You need to have morphology, you need to have immunophenotyping, you need to have cytogenetics, and all these together, you get the perfect diagnosis, which is very good for the patient in terms of treatment and outcome of the disease. Thank you.
Tulasiraman, can you hear me?
Yeah, ma'am, I can hear you.
Yeah, excellent presentation. Excellent.
Thank you, ma'am.
Very nice and very crisp.
Thank you.
I wish PGs were here to listen to all this discussion part of it.
Sure.
Very
sure.
nice. Thank you so much.
It's a pleasure, ma'am. I should thank you for giving me the opportunity.
Dr. Tulasi Raman,
Yes, ma'am.
how are you?
I'm doing good, ma'am. How about you, ma'am?
Yeah, long time since we met. Where
Yes,
are
ma'am.
you?
I'm with Apollo, ma'am. Apollo Hospital, ma'am.
Oh, good. Okay, a very good presentation, very useful
Thank you, ma'am.
for
Thank you.
practicing hematologists and pathologists.
Thank
Thanks
you,
for
ma'am.
Dr. Sita madam and yourself.
Thank you, ma'am. Thank you.
Very good slides and very good cases of diagnostic dilemma you have presented.
Sure. Thank you.
All the best.
Thank you. Thank you.
See you. Bye.
Sure. Thank you.
Thank you, sir.
Yeah.
Dr. Nandita Thakkar, a name to be reckoned with, is the academic head and coordinator at Mehta Multispecialty Hospitals, Chennai. She is also the medical director of Nandita's Fertility and Research Center. She is one of the most renowned gynecologists in the city with more than 25 years of experience offering end-to-end gynecological treatment. Her areas of interest include reproductive medicine, high-risk pregnancy, genetics and obstetrics and gynecology. I request Dr. Nandita Thakkar ma'am to share her vast experience regarding vital markers in gynecology.
Nandita.
Ma'am? Nandita ma'am?
Madam, I think mine has come. Madam, am I audible? Shall I start? Shall I start?
Yes, I don't know.
Oh,
Yes, sir.
yeah. Can I start?
Yes, sir.
Yeah. So, good morning all. I thank Sitalakshmi Madam and Dr. Akshit for giving me this opportunity. So, so molecular diagnostics, it's a very broad terminology. So I am going to stick on to only what is to be related with intensive care unit. Okay. So someone please change me the slide. Next one. So we have conventional PCR, multiplex PCR, proteomics, which deals with proteins, and genomics, which has the genetic component of the organisms being analyzed. Next one. So I am here to stick on with multiplex PCR because it is the most important modality which is being used in intensive care unit, and its implication in intensive care, advantages of using multiplex PCR, its limitations, and what's the future. Next slide, please. So as you all know, in contrast to conventional PCR, where we can detect only one target and one organism, this multiplex PCR can detect multiple organisms in a single test. And timely detection is very important because it optimizes treatment and it helps in infection control measures. Next. So this is how it looks.
Wait, I'll connect with the other meeting and give you.
I'll go. Who is coming with sepsis?
Wait.
Can I proceed? So what happened? Back. So next. Yeah. So any patient coming to ICU will be seen like this. So we don't have no clue whether it's a gram-positive organism, gram-negative organism, or fungal infection, or we have got some anaerobic infection. So what we routinely do is, next one. Next slide. So what we routinely do is, once a patient comes, we take a blood culture, we send it to the lab. Usually it takes 24 to 36 hours to identify an organism. At least it will take 48 to 72 hours to get the susceptibility test. If the organism is going to be a tough one, the growth of the organism is going to take more time, probably fungal organism, it is going to take 3 to 5 days. But if you take a molecular method, you can get the report in 5 hours. Next one. So you just imagine. So I am starting an antibiotic empirically versus a specific antibiotic. So empiric to specific antibiotic takes at least 3 days. So I am just imagining it is a bacterial infection. I'm starting on a broad spectrum antibiotic. Actually, patient is having a fungal infection. You just imagine after 3 to 5 days, I'll be getting a fungal report and I'll be starting an antifungal. So within this 3 to 5 days, patient will be having all multi-organ failure and it will be very tough to save the patient. And second problem with our empirical culture is if the patient is previously exposed, for example, if a patient comes from a remote place in a small hospital where they will be giving an antibiotic without taking culture itself. So if in that case, growth of the organism will not be there and it is very difficult to detect the organism. And if we delay in diagnosis, it increases cost and also morbidity and mortality of the patient. But the good thing with PCR is even if you treat the patient with prior antibiotics, we can identify the organisms as it detects only nucleic acids and within 5 hours. Next one. So this is the panel we have. So just imagine someone coming to you, you take 6 ml of blood, you have no clue patient is severely hemodynamically unstable, you just send all 3 panels. You send bacterial panel and fungi panel, you get the report in 5 hours, you start the patient on specific antibiotics. Can you imagine how much difference it will make? So if an intensivist, someone is listening to this, they will feel the difference. So it will save a huge amount of cost, time, and also life of the patient. Next. So you just take a patient coming to you with a Pseudomonas infection and also a Klebsiella infection. So Pseudomonas, usually what it does is it outgrows all other bacteria. So even if you grow this culture, it will only show Pseudomonas, it will never show Klebsiella. But if it is done with PCR, you can detect both the organism with 100% sensitivity. You just imagine you are treating Pseudomonas for 3 days, and after 3 days, you send the culture again, and patient goes Klebsiella. Your treatment for the patient starts only after day 4. So if you put a PCR, you can detect both the organism within 5 years. Next. Fungal identification. As you all know, it is really, really tough to get a fungal culture growth. And it is not only tough, it is very time consuming. So, and also sensitivity is very low. If you take a PCR, it has got real advantage in fungal culture than bacterial culture. Next. So you can see the comparison of culture with multiplex PCR. So the culture has shown negative, 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 where PCR has detected all the fungal organisms, with sensitivity being 100%. Next. So the PCR panel advantage, as I already said, it is very rapid, it is very specific to detect the organism, and you can detect in any blood, ball, or CSF. It does not depend on viable or growing bacterial culture. This is the advantage which it gives. Even if the patient was pre-treated with antibiotics, you can still get an organism. And also, multiple pathogens can be identified. So even if an organism outgrows others also, you can identify all the organisms. And faster initiation of specific treatment. Next. So you just imagine a patient is coming to you with fever, malaise, pulmonary infiltrates, hepatosplenomegaly, and the patient is an immunocompromised patient. Can you imagine how much antibiotics, antifungal, and antiviral needs to be started? It could be bacterial infection, fungal infection, or any of the 3 viral infection. Next. So if you do a PCR, you have all the 3 viruses covered in a single panel. You can get a result in 5 hours, and it is more sensitive, and it saves so much of cost. If it is only this one of the viral infection, you can confine your treatment to that one particular infection instead of treating patient for bacterial, viral, and fungal infection. After 5 days, you will come back to this fungus. Next. So coming to the benefits to the patient, it detects early and it detects the specific organism. It saves a lot of time, and it detects multiple organisms, avoids long duration of empirical antibiotics, and it has less mortality and morbidity, it decreases cost, and less volume of blood samples required. So if you work in intensive care, you will know this. To take fungal culture and blood culture, it is going to take at least 40 ml of blood. Can you imagine how tough it is to take 40 ml of blood from a patient who is really very sick? Next. So next generation sequencing, this is going to be the endpoint in precision diagnosis. So having a genomic library and comparing the genes in the sample. So it not only detects the already known organism, with this genome, you can detect the unknown organism also, cross kingdom also. Next. So even though there is next generation sequencing coming, multiplex PCR is always the first step and also the most important step, because it identifies early and cost effective. And I really thank this Rivara for providing me with the slides. Thank you all.
Thank you, Jatin. I think it was very crisp and very nice talk. I think you spoke to the point. And it is something which we face almost every day when we have a patient with sepsis, and you're also calling me and finding out what organism it is, or it is the rigmarole which happens with the culture. I hope the molecular lab makes your life easy and all the intensivists' life easy way forward. Thank you
Definitely.
So much.
Of all the 3 departments, probably the intensive care will be the most beneficiary department, because we are going to do it a day in, day out.
I'm sure.
Yeah, that was very nice, Jagan, and you made
Thank
it
you,
very
madam.
simple for a person who is not exposed to microbiology at all.
Madam, that's why I made it maximum at the maximum simple.
Yeah, it is Greek and Latin, and you made it very, very simple. I'm very happy about it.
Thank you, madam. Thanks, madam.
Thank you, sir. Now we have Dr. Nandita Thakur, Academic Head and Coordinator at Mehta Multi-Specialty Hospital. She would be talking on her vast experience regarding the viral markers in gynecology.
My slides.
Yeah. Yes.
Yes, ma'am, we can start, ma'am.
Yeah, very good morning, and I'm sorry for the little delay because we were just doing a case and it got postponed. Okay, I thank the team from the lab for having me to talk on this subject, viral markers in gynecology. The molecular aspects. I think molecular genetics is going to take up a lot of and invade into almost all the areas, and we have a lot to do out of this. So just to introduce, what is a molecular diagnostics? It's a very broad terminology. It helps to diagnose the health status at a molecular level. It detects the RNA, DNA, or the proteins sequences, and these are specific for particular diseases, viruses. You talk about FSH polymorphism. There are many things it invades. So I will just restrict this particular talk to what are the viruses that we are looking at. So that slide is not very clear, I think. Okay, the test can be performed as a genetic test, which gives information like, for example, cancer therapies. There are specific gene tests that we look at. Microbial cultures help to find out what is the organism and what is the antibiotic that will work in such cases. And it can be used for diagnosis, detection, diagnosis, and treatment of certain conditions that will help us successfully manage any infection, any viral infection. Slide, please. Next slide. See, the most common thing in gynecology, I think most of us have started doing this, is co-testing, is the human papilloma virus. We are all out to screen for cervical cancers, try to pick them up in an early stage. So this is one of the most common, and we are almost, I think, a decade doing it for HPV testing. It is one of the most common viral infections. It is associated with cervical cancers, oropharyngeal, anogenital cancers, and genital warts. HPV infection, as you see, the majority of them are asymptomatic and they would resolve spontaneously. Persistent infection is the one which will go on to form cancer. So when we screen, and we screen for the precancerous lesions and we identify the case early, we can almost give a very good treatment for this particular patient. Slide, please. If we look at the HPV panel, there are many subtypes like HPV types. Next slide, please. Okay. The HPV types are divided into high risk category and the low risk category. The highest in the box is boxed off as 16 and 18. The type 16 and 18 are oncogenic, and If we identify them, then that means that lady is for very close follow-up and monitoring. We know that most of them can be picked up with the pap smear or the LCB, liquid-based cytology, and the cancer cells start forming at the squamous columnar junction. And at this time, when the HPV infection attacks that particular metaplastic area, the risk of developing squamous cell carcinoma is almost 99.7%. But if you take adenocarcinoma of the cervix, for example, these women, if they are less than 40 years, then they have a lesser probability. That is, their HPV is present in about 89% of adenocarcinomas. And if they are more than 60 years, the HPV observed in that is around 43%. So basically, the most common that we are looking is this squamous cell carcinoma and the adenocarcinoma. And if these HPV viruses, which are more oncogenic, are there, the risk of developing a cancer is very, very high. So we have moved a long way. The screening techniques have come a long way. First is just visual inspection with acetic acid and Lugol's iodine. That has got a medium sensitivity and specificity. Then comes pap smear, the traditional conventional pap smear. Then we have moved on to the liquid-based cytology. So this also has a low sensitivity but a high specificity. To this, when we add another element, like the molecular testing of the HPV DNA testing, the identification of a high-risk HPV is becoming very, very advantageous in identifying women at risk. It has got both a high and a sensitivity and a specificity. So this is called co-testing. So when we co-test liquid-based cytology, we can get it from the same sample. It makes diagnosis better and management of this patient much, much better. Slide, please. There's a very interesting study on the risk stratification. When the next slide. In this slide, you can see two areas. The first is there was some abnormality seen, and when the HPV testing was done, it gave a high detection rate. When there was no cytology, no finding, then the HPV testing, when it added more value. So it doesn't mean that we have to see a lesion every time. Just adding on the HPV testing changed the whole scenario. Today, the guidelines are slowly changing. Even it's almost been 7 to 8 years. The WHO guideline says HPV testing now will become the first line for screening for cancer cervix. Slide, please. So HPV is actually here to stay, to detect and help diagnose early precancerous lesions. And the treatment is almost that 80% can be treated early. The next in the virus range is the herpes simplex virus. The molecular diagnostic helps both in diagnosis and screening. Diagnosis, early diagnosis, and prevention of transmission. It can also be used for patients who are asymptomatic or they are viral shedders. So this also helps in preventing the transmission to the partners. This is both for herpes simplex 1 and 2. The other thing is we are bothered about the vertical transmission from the mother to the baby. So if we find a HSV compared to the IgG or IgM screening, when we add this, the molecular level, definitely the diagnosis is there and treatment can be initiated early. Slide, please. So what are the advantages? Next slide. Yeah, next, the other one. No, next slide, please. Yeah. What are the advantages of doing a RT-PCR versus any culture? It is a very, very sensitive method. It is helping detecting asymptomatic shedding in HSV, sensitive and in the absence of any clinical ulcers, lesions, and less turnover time. That means the identification in a very small stipulated time is easily obtained, and the samples can be collected just by using this sterile swabs. Slide, please. This next set of viruses which come through. It is called the triple H. I think all of us as gynecologists have started doing HIV, hepatitis, B, and now hepatitis C also has become a part of the screening program. So the 3H screening at molecular levels. So what does it do to us? Slide, please. If you look at hepatitis B, our teaching was to look at serological markers like HBsAg, or you look at HBeAg, or you look at the antigen or the antibody, or you look at the liver enzymes. What is molecular testing done? The quantification of the virus. We are looking at a viral load. We are looking for chronically infected individuals who are carrying the virus, or are they there in the infective stage, or after therapy has their load decreased. So this, at this level, molecular testing, this is what is being recommended by the WHO. For hepatitis C, which is a major cause of liver disease. Next slide, please. Major cause of liver disease, cirrhosis, and hepatocellular carcinoma worldwide. An accurate diagnosis is obtained using molecular testing to find out apparently symptom-free carriers, or whether they are having an active and a chronic infection can be identified. Levels of HCV RNA remain relatively unstable over time in chronically infected patients. And HCV has got 7 genotypes. So molecular techniques will become a gold standard in finding which is the genotype in this particular patient, and detailing in treatment also would be there. How do we detect? The next slide, please. Detection of hepatitis with molecular markers. Next slide. Yeah. So, hello. Am I audible? Hello.
You're audible, ma'am.
Yeah, okay. So there is a sequence where we can quantify, we can find out what is the sensitivity of this test, how we detect it, and after therapy, how the effect of the therapy, whether the viral load has decreased, or if they are not responding, we can also estimate the drug resistance. Most important is, we are, as a gynecologist, I would be worried about the vertical transmission to the fetus. So identifying all this, especially in HIV or a hepatitis, the vertical transmission is what we are worried. So if a patient is on treatment or any form of therapy, it will definitely help us to say, okay, now this patient is relatively, the viral load is less, is asymptomatic, and it can be, they can go ahead with some treatment. Even in infertility, we look whether, you know, the viral load is less, whether the husband can give his sperm for further treatment, because we know even the seminal plasma can contain the HIV organism. So HIV diagnosis is very, very important, and molecular markers will help us further get to, you know, fine tuning the treatment approach. Slide, please. Slide. So this sort of sums up of what I have said. So what is it that we are looking at? To the patient population needing these tests, combined tests of these 3 viruses, it helps in immediate treatment and to approach a susceptible population. This sums up the HIV screening, especially while giving a pregnant woman, or in case of any blood transfusion setting where you need reports, or whether we are doing an ICU patient, which Jagan has mentioned. All these help us to manage the patient more effectively than our older methodologies of diagnosis. So the take-home points of this will be, HPV testing has been standardized to a lot of level. The high-risk types can be identified and early precancerous lesions can be done. The triple H screening is useful in susceptible population. Herpes simplex virus 1 and 2 and the can also prevent in mother-to-fetal transmission. I thank the group for giving me this opportunity to share the viral markers which we use in daily practice. And thank you very much, ma'am. And thank you, Rivera, for your help with the slides, which is very useful. And I hope many of us would use the facility available to provide better patient care.
Thank you, Nandita. You're able to hear me? Are you able to hear me?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
It was a very crisp presentation, especially the triple screening, which is of very vital importance to all the susceptible group, was a highlight of your talk. Extremely thankful to you for your talk, Nandita. Sweta, you have anything to add?
Madam, Dr. Premlata here. Dr. Nandita
Yes,
has told everything about all HIV, hepatitis B, everything. I think it must be very clear to everybody. We are happy that molecular genetics has come to the level. We have to get used to all these modalities nowadays. Okay, madam. Thank you, madam.
Thank you, Premlata.
Okay, madam.
Thank you.
We'll move on to the next session. Dr. Manikandan is a young and energetic surgical oncologist at Mehta Multispecialty Hospital and plays a key role in tumor board. He did his undergraduation and post-graduation from Government Medical College, Calicut, and MCH Surgical Oncology from King George Medical University. He has many awards and recognitions to his credit, including the prestigious Professor N.C. Mishra Memorial Gold Medal. We now have an interesting case-based discussion on how molecular testing guides cancer treatment. Over to you, sir.
Dr. Manikandan, just see whether he's unmuted.
Manikandan, sir.
Message now. Next phase online now. Just message them.
Yes, messaged. Due to some emergency, I spent time to prepare for this and be part of this, but due to this rescheduling, I'm not able to participate as I have to go back to attending the problem for which I am here. I understand all are seniors, but maybe next time, otherwise.
Due to an emergency, Dr. Manikandan sir couldn't join. So we end up the session and we thank you all for joining us and supporting us. Thank you.